Welcome back to the Vital Signpost. I think it's safe to say that if you're listening to this, you're likely a nurse or a nursing student. And no matter how much experience you have under your belt, there's always more to learn.
That's the truth.
Today, we're taking a deep dive into antihypertensive drug therapy, which, let's be honest, is something you're going to encounter practically every day, especially if you work with adults.
Absolutely. And it's not just about knowing the medications. It's about understanding how they work and how to apply that knowledge to provide really safe and effective care to our patients.
Right. It's about connecting the dots between the science, the individual needs of each patient, and the nursing interventions that can truly make a difference.
That's the goal.
So to kick things off, let's revisit something that might seem basic but is absolutely fundamental, the autonomic nervous system.
Yeah, the autonomic nervous system is like the behind-the-scenes conductor of our cardiovascular system, constantly making those fine adjustments to our blood pressure through the interplay of its two branches, the sympathetic and the parasympathetic nervous system.
It's a constant balancing act, right?
It really is.
On one side, we have the sympathetic nervous system, our fight-or-flight response that kicks in when we're stressed or need an energy boost,
Mm.
increasing our heart rate, constricting those blood vessels, and ultimately raising our blood pressure.
Exactly. And then we have the parasympathetic nervous system, which is more like our rest and digest system.
Yeah.
It counteracts those effects, slowing the heart rate, relaxing those blood vessels, and bringing the blood pressure back down.
And it's this constant push and pull between those two systems that keeps our blood pressure within that healthy range.
That's the ideal scenario.
But of course, when that balance is disrupted, well, that's when problems can arise.
Hmm.
And one of the most common consequences is, you guessed it, hypertension, or as most people know it, high blood pressure.
Yeah.
Now, I know we use the term hypertension all the time in nursing, but it's worth taking a moment to define it precisely. What exactly are we talking about when we say hypertension?
That's actually a very important question. I mean, how can we effectively manage something that we don't fully understand? So, according to the current guidelines, for anyone over 60, hypertension is defined as a systolic blood pressure greater than 150 millimeters of mercury or a diastolic exceeding 90 millimeters of mercury.
Okay, so 150 over 90 for those over 60.
Exactly. Now, for anyone under 60, especially if they have diabetes or chronic kidney disease, that threshold is a bit lower at 140 over 90.
Got it. So age and underlying conditions play a role in how we define hypertension.
They really do.
Now, let's talk about the two main types of hypertension. I know this is a bit of a throwback to nursing school, but I think a refresher is always helpful. Primary and secondary hypertension.
Oh, absolutely. So primary hypertension, also known as essential hypertension, makes up the vast majority of cases. And the truth is, it's a bit of a medical mystery. We don't fully understand the root cause. It probably involves a mix of genetic predisposition, lifestyle choices, environmental factors. It's complicated.
So essentially, with primary hypertension, the exact cause is unknown.
Pretty much. But secondary hypertension is a bit more straightforward. This type stems from an identifiable underlying medical condition. Think kidney disease, adrenal gland disorders, or even certain medications.
So it's like a detective case, you know? You need to figure out the underlying cause to effectively manage the hypertension.
Exactly. That's why taking a really thorough patient history is absolutely crucial. By asking the right questions and just looking for those clues, we can determine if the hypertension is primary or secondary, which of course will guide our treatment approach.
It's all about connecting the dots, right?
Yeah.
Looking beyond just that blood pressure reading and seeing the whole patient.
100%.
Now, let's talk about why uncontrolled hypertension is such a big deal. It's often called the silent killer
And for good reason.
because it can quietly damage your blood vessels and organs for years without any noticeable symptoms.
Right. You might not even know anything is wrong.
Exactly. And it's a major risk factor for a whole host of serious conditions: coronary artery disease, stroke, heart failure, kidney failure. And it can even impact your vision and your cognitive function. I read somewhere that the risk of developing cardiovascular disease doubles with every 20 millimeter mercury increase in systolic pressure or a 10 millimeter mercury increase in diastolic pressure.
Those are some pretty sobering statistics, and it really highlights the urgency of addressing hypertension. It's not just about lowering numbers on a chart. It's about protecting our patients from some really serious complications.
Absolutely. Now let's shift gears and talk about the weapons we have to combat this silent killer. We're talking about antihypertensive drugs. And we're lucky because we have a whole arsenal of them.
It is like having a toolbox, right?
Yeah.
We have diuretics, adrenergic drugs, vasodilators, ACE inhibitors, ARBs. calcium channel blockers, and direct renin inhibitors.
Each class has its own unique way of working, its own advantages and disadvantages.
And choosing the right drug or the right combination of drugs for each patient depends on a whole lot of factors: their age, other medical conditions they have, their lifestyle, even their personal preferences.
Right. And the current guidelines we talked about earlier often recommend diuretics as the first line of treatment for hypertension, but we'll delve into that a bit later. For now, let's focus on one specific category: adrenergic drugs.
Sounds good.
These medications work by targeting the sympathetic nervous system, that fight-or-flight response we were discussing earlier.
Right. They basically interfere with the sympathetic nervous system's ability to increase blood pressure. In a way, they help calm things down.
Within this adrenergic drug family, we've got a few subcategories.
We do.
We've got centrally acting alpha-2 agonists, peripherally acting alpha-1 blockers, beta blockers, dual-action alpha-1 and beta blockers, and those peripherally acting adrenergic neuron blockers.
5 in total.
So let's start with those centrally acting alpha-2 agonists. These meds work directly in the brain.
They do.
They stimulate alpha-2 receptors, which in turn reduce the sympathetic outflow from the brain.
It's kind of like turning down the volume on that fight or flight response.
So basically, these drugs are working at the source, the brain, to reduce those signals that would normally lead to vasoconstriction and a faster heart rate.
Exactly. And by doing that, by reducing that sympathetic outflow, they also reduce the production of norepinephrine, which, as you know, is a major player in regulating blood pressure.
And they also impact the kidneys, right?
Oh, yeah. They reduce the activity of renin, which is an enzyme that's super important in that whole renin-angiotensin-aldosterone system. That's a mouthful. But it's a complex system that can really crank up blood pressure.
So centrally acting alpha-2 agonists are really working on multiple fronts to lower blood pressure. Now let's move on to those peripherally acting alpha-1 blockers. These meds take a slightly different approach.
They do. Instead of working directly in the brain, they target those alpha-1 receptors that are located directly on the blood vessels.
I see.
So by blocking these receptors, they prevent the blood vessels from constricting, which allows them to relax and widen.
So they're working at the level of the blood vessels themselves to reduce that peripheral resistance.
Right. And this effect is especially noticeable in arteries and veins.
Interesting.
And just as a side note, alpha-1 blockers are also used to improve urinary flow in men with benign prostatic hyperplasia. Because they relax smooth muscle, they can help with that as well.
So they have benefits beyond just blood pressure control.
Yeah.
Now let's talk about beta blockers. I think most nurses are pretty familiar with these.
They're definitely a mainstay in cardiology.
What exactly are they doing?
Well, beta blockers, as the name suggests, block beta receptors. Specifically, they target beta-1 receptors in the heart. And by blocking those receptors, they reduce the heart rate and the force of contraction. Basically, they slow things down in the heart, which in turn reduces cardiac output and ultimately blood pressure.
So their main target is the heart, but they also have an effect on the kidneys, right?
Yes, you're right. They reduce renin secretion from the kidneys. And remember, renin is what kicks off that whole cascade that leads to vasoconstriction. So by reducing renin, beta blockers are indirectly helping to control blood pressure.
It's fascinating how everything is interconnected. Now, we also have dual-action alpha-1 and beta blockers, which I assume combine the effects of both alpha and beta blockade.
You got it. They hit both heart rate and vasodilation.
A two-for-one deal.
You could say that. It's a more comprehensive approach to managing hypertension.
So we've covered 3 out of the 5 subcategories of adrenergic drugs. Ready to tackle the remaining 2.
Let's save those for part 2 of our deep dive. Stay tuned. Welcome back to the Vital Signpost. Before we dive into the last 2 subcategories of adrenergic drugs, I think it's important to touch on some key nursing considerations for this whole class of medications.
Right. Because at the end of the day, it's not just about knowing the pharmacology, it's about using that knowledge to provide safe and effective care.
Exactly. And one of the most common side effects we see with these drugs, especially the alpha blockers, is orthostatic hypotension.
Ah, yes. That sudden drop in blood pressure when someone stands up.
Right, and it can make people feel dizzy, lightheaded.
And even lead to falls.
Especially in our older patients, falls are a huge concern, so it's really important to educate our patients about this. Let them know it's a possibility.
And give them strategies to manage it.
Absolutely. Tell them to change position slowly, avoid standing for too long, and stay well hydrated.
And if they do feel lightheaded,
sit or lie down right away.
Simple things, but they can really make a difference.
They really can. Now, another common complaint with adrenergic drugs is dry mouth.
Yeah, that can be really bothersome.
It can. It might seem like a minor thing, but it can really impact a patient's quality of life. Makes it hard to swallow, taste food, even talk.
I've had patients tell me it's really uncomfortable.
Absolutely. And, there are some simple things we can recommend, like sugar-free gum or hard candy, just to stimulate saliva production. Sipping on water throughout the day can also help. And for those who are really struggling, there are over-the-counter saliva substitutes.
Right. It's important to address those seemingly small side effects because they can affect whether or not someone takes their medication.
Absolutely. We want to be proactive. Now, this next one's a bit more delicate, but it's important to talk about sexual dysfunction.
That's definitely a sensitive topic.
It is, but it is a potential side effect of a lot of antihypertensive drugs, including some of those adrenergic drugs.
And it can be really distressing for patients.
Absolutely. So, we have to approach this with sensitivity, empathy, and create a safe space for patients to talk about it.
Make sure they know it's okay to bring it up.
Exactly. We need to let them know it's legitimate concern, that they're not alone, and that we're there to help.
And sometimes adjusting the dosage or switching to a different medication can make a difference.
That's right. Okay, so let's circle back to those adrenergic drug subcategories. We covered centrally acting alpha-2 agonists, peripherally acting alpha-1 blockers, and beta blockers. Next up are the dual-action alpha-1 and beta blockers.
The 2-for-1 drug.
Yeah, basically. These block both alpha-1 and beta receptors, so they work on both the heart rate and the blood vessels.
More bang for your buck.
In a way. And that can be really helpful in certain situations. It offers more comprehensive blood pressure control.
Makes sense. And finally, we have those peripherally acting adrenergic neuron blockers.
Right. These work by inhibiting the release of norepinephrine from those sympathetic nerve endings.
Norepinephrine, the vasoconstrictor.
That's the one. So by reducing its release, these drugs decrease that sympathetic activity and lower blood pressure.
Okay, so that covers all 5 subcategories of adrenergic drugs. It's quite a diverse group.
It is. And each subcategory has its own little quirks, its own side effects to watch out for. As nurses, it's really important that we understand all of that so we can provide the best possible care.
Individualized care tailored to each patient. Now let's move on to another heavyweight in the antihypertensive world, ACE inhibitors. These guys interfere with the renin-angiotensin-aldosterone system.
The RAAS, a real mouthful. But basically, this system plays a huge role in regulating blood pressure.
And ACE inhibitors, they kind of throw a wrench in the works, right?
They do. They prevent the conversion of angiotensin I to angiotensin II, which is a super powerful vasoconstrictor.
So by reducing angiotensin II, you're essentially relaxing those blood vessels, lowering that peripheral resistance, and bringing the blood pressure down.
Exactly. And here's the really cool part. Besides lowering blood pressure, ACE inhibitors also have some pretty amazing cardioprotective effects.
I've heard they can actually help protect the heart after a heart attack.
That's right. They help prevent ventricular remodeling, which is basically the heart muscle getting weaker and changing shape after a heart attack. They can also reduce the risk of death in patients with heart failure. And they protect the kidneys, too, especially for people with diabetes.
Wow, that's impressive. But, of course, like any medication, there are potential downsides, side effects we need to watch out for.
For sure. One of the most common and often the reason people stop taking ACE inhibitors is a dry cough.
Persistent, annoying dry cough.
That's it. And it's thought to be caused by a buildup of bradykinin, which is normally broken down by ACE. But since ACE inhibitors, inhibit ACE, bradykinin can build up and trigger that cough.
Makes sense. So what else should we be on the lookout for?
Well, first-dose hypotension is something to keep in mind. Basically, it's a sudden drop in blood pressure after that very first dose.
Which is why we always start with a low dose.
Exactly, and monitor those patients closely.
Especially if they're already dehydrated or taking other meds that could lower blood pressure.
Exactly. Another thing to watch out for is hyperkalemia.
High potassium.
Right. ACE inhibitors can increase potassium levels, so we need to keep a close eye on that, especially in folks with kidney problems or those taking other medications that affect potassium.
And then there's angioedema.
A rare one, but serious. Rapid swelling of the face, tongue, throat.
Definitely something we need to catch early.
Absolutely. It can be life-threatening, so it's crucial that patients know the signs and symptoms.
And that they seek medical attention immediately if they experience it.
Right. So lots to think about with ACE inhibitors. The good, the bad, and the potentially ugly.
For sure. Now, what about ARBs? They seem to be gaining popularity as an alternative to ACE inhibitors.
They are, and they work a little differently. ARBs, or angiotensin the second receptor blockers, they don't block the production of angiotensin the second, they block its action.
They basically intercept the message before it gets delivered.
That's a great way to put it. And one of the great things about ARBs is that they don't seem to cause that pesky dry cough as often as ACE inhibitors do.
That's because they don't mess with bradykinin breakdown, so no buildup, no cough. So in terms of effectiveness, how do they compare to ACE inhibitors?
Well, they appear to be just as good at lowering blood pressure.
Good to know. But I'm guessing they still have their own set of potential side effects?
They do. Hyperkalemia is still a concern, though maybe not as much as with ACE inhibitors, and we still need to be very cautious about potential harm to a developing fetus.
So still contraindicated during pregnancy.
Absolutely. So we've covered ACE inhibitors and ARBs, two big players in our hypertension fighting toolkit.
What about those other key players we mentioned earlier? Calcium channel blockers, diuretics, and direct vasodilators.
Let's save those for part 3. Stay tuned.
Welcome back to the Vital Signpost. We've been exploring a whole range of antihypertensive drug classes, from those adrenergic drugs to ACE inhibitors and ARBs.
A lot to cover.
It is. But we're not done yet. We still have a few key players to discuss: calcium channel blockers, diuretics, and direct vasodilators.
Each one has its own unique way of tackling hypertension. And as we've been saying, understanding these nuances is key to providing the best care for our patients.
Couldn't agree more. So let's start with those calcium channel blockers, often called CCBs. I always picture CCBs as these little relaxers for our blood vessels.
That's a good way to think about it. They help those blood vessels chill out and whiten.
Exactly. So how do they actually work?
Well, calcium is super important for muscle contraction. That includes the smooth muscle that lines our blood vessels.
Okay.
CCBs block the entry of calcium into those smooth muscle cells. So basically, they prevent those muscles from contracting, which leads to vasodilation.
And vasodilation, of course, lowers blood pressure.
Right. It reduces that peripheral vascular resistance.
And CCBs, they're not just used for hypertension, right?
Nope. They're pretty versatile.
I've seen them used for angina, certain heart rhythm problems, even migraines and Raynaud's phenomenon.
Exactly. They're great for any condition where that vascular constriction is a problem.
Now, on to a class of drugs that are practically synonymous with hypertension management: diuretics.
Those trusty water pills.
The workhorses.
They work by increasing urine output. Basically, they help flush out excess fluid from the body.
So less fluid means less blood volume.
Right. And less blood volume leads to lower blood pressure.
Simple but effective.
And within that diuretic family, we have a few different types: thiazide diuretics, loop diuretics, potassium-sparing diuretics.
Right. Thiazide diuretics like hydrochlorothiazide.
Yep, that's a common one. They're usually the first choice for hypertension because they're generally well-tolerated and effective.
Yeah, I think they align with those current guidelines we mentioned earlier, recommending diuretics as the first line of treatment.
They do. They've been shown to reduce cardiovascular events, plus they're usually pretty affordable and easy to get. But as always, we have to watch out for potential side effects.
Electrolyte imbalances come to mind.
Yes, especially hypokalemia, low potassium.
So monitoring electrolytes is key.
Absolutely. And we might need to think about potassium supplements in some cases.
Okay, so we've talked about CCBs and diuretics. What about those direct vasodilators? They sound pretty intense, acting directly on those blood vessel walls.
They are pretty potent. They relax the smooth muscle in the arteries and veins, which leads to vasodilation and a drop in blood pressure.
Medications like hydralazine and sodium nitroprusside.
Exactly. Sodium nitroprusside, that's the one we often use in hypertensive emergencies when we need to lower blood pressure quickly.
Makes sense.
But because it's so strong, it needs very close monitoring.
Because of that risk of severe hypotension.
Right.
Well, it seems like we've reached the end of our deep dive into antihypertensive drug therapy. We've explored so many different classes of drugs: adrenergic drugs, ACE inhibitors, ARBs, CCBs, diuretics, direct vasodilators.
It's a lot.
It is, but it's vital knowledge for nurses who are caring for patients with hypertension. We're the ones monitoring them, assessing their response to treatment, educating them about their meds, advocating for their well-being.
Absolutely. We're right there on the front lines.
We're playing such a crucial role in helping our patients manage this often silent but very serious condition.
It's about reducing the risk of those complications we talked about.
Exactly. Those heart attacks, strokes, kidney problems. It's about helping our patients live healthier lives.
Couldn't have said it better myself.
Thank you for joining us on the Vital Signpost. Until next time, keep those vital signs in check.